Hi there, this is your moderator Lori Dearman, and you're in the right place for advancing remote patient monitoring through new coding options, featuring Bill Broderick and Caleb DeRosier. And in just a moment, I'll be introducing our speakers, as today's webinar is about hearing from these experts as they share the current state of telehealth reimbursement, discuss various scenarios of how to use the S code and the existing T codes to bill for telehealth related services, and answer your questions. But for now, let's get started, as we do have a lot to cover. We've invited you along with over 650 professionals registered from 47 states and provinces representing a variety of healthcare channels. Regardless of your role or location, we're confident that you'll find today's webinar of value. Now, speaking of feedback, let's get some from all of you in the way of our first poll for the day. Coming up on your screen is that first question, and we would like to know, how are you currently being reimbursed for telehealth services? Is it fee-for-service, capitation including bundled payment for home health, grant or government funding, no reimbursement, or other? All right, looks like we have 19% of you saying fee-for-service, 6% capitation, including bundled payment for home health, 7% grant or government funding. That front runner there, 55% saying no reimbursement, and 12% saying other. Very interesting results. Thank you so much for sharing them. I know our speakers appreciate the insight. Now, speaking of our speakers, I am very excited to welcome two real thought leaders in this space, Bill Broderick and Caleb DeRosier, who will be addressing today's topic. Now, Bill is going to get us started with a brief overview of Bosch Healthcare and their role in the creation of the S code, followed by Caleb, who will cover relevant codes and forms, provider and payer segments, the new S code, and examples to request S code adoption and payment. And then back to Bill to give us some of the next steps. But before I do turn it over to Bill, first a few words in the way of an introduction. Bill Broderick is North American Head of Marketing and Global Head of Outcomes Research for Bosch Healthcare. He has 30 years experience of healthcare experience as an educator, hospital administrator, home health executive, and consultant. He was the practice leader for payer and reimbursement strategies at Ingenix, focused on using health economics and outcomes research to prove the value of new and commercialized pharmaceuticals. He founded and led the evidence-based sales department at Quintiles, the world's largest CRO. His current focus at Bosch is to help drive national coverage for content-driven telehealth-enabled care coordination. Bill, welcome to the webinar. How are you today?
I'm excellent, Lori. Thank you so much, and thank you everyone on the phone for joining our webinar today.
And Bill, can you get us started then with some background on Bosch Healthcare and Bosch's role in advocating for the S code?
Absolutely. Let me give you a little bit of background on Bosch. Most of you may have heard of the company Bosch. We're a 125-year-old company. We were founded by Robert Bosch in Germany. It is a privately held company, 92% of it owned by a charitable foundation. And in 2012, we had over almost $70 billion in revenue and had over 306,000 associates worldwide. So a lot of you on the phone know Bosch either for commercial kitchen appliances or our power tool division or a lot of the work that we do with car parts. But Bosch is a whole lot more than that, including Bosch Healthcare. So since 1998, Bosch Healthcare has been one of the largest and biggest thought leaders in telehealth solutions. On any given day, we connect over 50,000 patients with their care teams, and we have an extensive portfolio of intellectual property that is all around remote patient monitoring. We have a lot of clinically validated outcomes across different segments, whether it's the VA, the commercial space, Medicaid, Medicare, etc. Our solutions at home are really driven through multiple interfaces, including our Health Buddy and our T400 devices. Our claim to fame and what we think really truly differentiates us in the marketplace is our evidence-based clinical content that is disease-specific with very deep branching logic and vital sign monitoring for patients. We offer a wide variety of telehealth solutions, whether it is something focused in the post-acute space or basically taking care of patients who need chronic care. We wanted to give you a little bit of background on our evidence. Bosch Healthcare is the #1 company in the world in terms of evidence around its solutions. We have over 40 publications in peer-reviewed journals that have measured the impact of these solutions over time. And we're getting new publications each day. Each month, there's new publications that are being added to the literature. The vast majority of these are done by our customers, people who've been using the Health Buddy in care settings and have published the results independent of Bosch. If you think about how we divide outcomes of these publications, the first one would be kind of clinical outcomes. We have several publications that talk about the impact of our telehealth solutions on mortality of patients, that if you are consistently using Health Buddy, we can reduce your mortality compared to control groups. Also, studies which have indicated the impact of Health Buddy and T400 on improved quality of life. If you think about another category, this middle category around patient empowerment, there's publications that talk about how telehealth interventions drive better compliance around medication adherence and treatment recommendations around diet and exercise and things like that. One of the most important outcomes is how our products help improve patient disease knowledge. The more that patients understand about their disease, the more that can lead to that patient self-managing themselves, which we see is probably the #1 driver of our outcomes, is this idea of patients graduating from being somewhat passive in their disease state to actively self-managing it. And then finally, we have this whole area around costs and financial outcomes. And a lot of the publications talk about how the impact of telehealth can significantly reduce costs of populations, mostly driven by decreased rates of hospitalizations and readmissions. Other things have been looked at, including research utilization, such as reduction of bed days of care and fewer ER visits. So why is this important? Because these publications served as the foundation for the story of how this S-code was developed. Bosch Healthcare, like many of the providers out there, have really struggled with how do we get some type of better reimbursement for telehealth. And in the poll, it indicated that most of you, there's no reimbursement. And part of reimbursement has to do with how do you bill for something? What are the codes that you need to actually, from a provider perspective, work with a payer to get reimbursed? In the past, the codes that were available were inadequate. So we were trying to work with CMS to figure out how we could develop a HCPCS code that would be much more comprehensive, that would provide standardization for payers operating in multiple states, promote physician adoption of telehealth, and allow management of multiple conditions beyond heart failure as it's defined by payers, how to address clinical coordination provided by a care manager and supported by a physician, and how to emphasize the role of clinical content, behavior assessment, and patient education in telehealth. It's not just about vital sign monitoring. So back in 2012, we went to CMS and we applied for a new HCPCS code. They basically came back and said, we don't think there's a real need for one. So not taking no for an answer, we went back to our friends, some of our commercial clients, as well as some Medicaid state agencies, and came back to CMS with more support around that and our evidence. We got to present this revised request back in May to CMS HCPCS work group in Washington. This was presented by our medical director, Karen Gilbert. And in November, Bosch received a letter from CMS indicating that this new code had been granted and available for use in January 2013. So with that background, let me turn it back over to Lori, who will introduce Caleb and move on to the next section.
Thank you so much, Bill. And Folks, next up we do have Caleb DeRosier, a counsel at Foley Hoag LLP, a global legal and advisory firm focused on strategic healthcare policy and reimbursement. Caleb's background includes launching a healthcare advisory firm as well as holding executive positions at the Centers for Medicare and Medicaid Services, CDM, Omnicom, Blue Cross and Blue Shield of Massachusetts, Pfizer, and Roche Pharmaceuticals. A seasoned global speaker and published writer, Caleb holds a JD and an MPA. Caleb, so glad you could be with us today. How are you?
Thank you, Lori. Very good to be here and being part of this webinar. Very exciting.
Now, I imagine that most folks on today's call know a thing or two about coding, but could you get us started off with an overview of S codes?
Sure. So under this section, we're going to go over a brief overview of S codes and the codes that different payers are using. We also know that from the results of the survey, you're either getting no reimbursement or limited reimbursement. So as Bill indicated, you could have a strong code set, but no reimbursements attached to them. So we're going to talk about how that can be applicable. So the S codes in a nutshell can be used for a variety of items and services. As you may know, it's used once it's awarded. It could be used nationally by commercial payers and state Medicaid agencies that have decided to cover telehealth as an optional benefit. It captures all components of the procedure once it is uploaded by the payer for purposes of coding, tracking, and reimbursement. And for purposes of this S code, as Bill indicated, we worked throughout the year with providers and payers and made our case to the HCPCS working group, and it went into effect on January 1, 2013. So as many of you know, there is chaos in codes and reimbursement, and there is resistance to reimbursement. But what we've seen from the payers that have adopted not only this new code S9110, which we're going to describe in full detail, and other codes, that there are T codes as well, or HCPCS codes that relate to these services, whether it's T code 1014 regarding telehealth transmission, T code 2023 targeted case management, or some have even used T code 599. Those were adopted in 2001, 2003, and 2004 respectively. When you see a coverage policy with codes, it could have a laundry list. The payer then decides which one they want to use for our services or for other services that you may apply. But in the end, some of these codes have payment attached to them. And so we want to talk about how we can be more proactive with these commercial payers, Medicaid, and others that are covering it to try to make sure that there's adequate reimbursement as well. So basically, this is a library of codes that are blended or put on a coverage policy for purposes for you, the provider, to use to put on the claim forms for reimbursement. We can get into some details of some, but our focus today primarily is on this new S code 9110 that is basically an opportunity for us to engage payers, for us to get to really update their policies and update their reimbursement so that you as the provider can hopefully get reimbursed for your services. So what is this new S code for remote monitoring? One of the ways we engaged CMS was that we asked them to discontinue a code that was very narrow and limited to a disease state, and they agreed with us because the world is changing. Folks that are receiving care or consultation remotely with their providers is broader than just a disease state. So this was a big win in that regard. And as you can see from the description, it specifically requires consultation telemonitoring of patient in their home and includes all necessary equipment, computer system, connections and software maintenance, plus patient education and support. We think that is a novel way to continue to refine these codes to make sure that folks that are and providers that are caring for patients in these settings can have the appropriate code, and that payers can also track and pay for these services as well. Many of you indicated that you're primarily getting paid through a fee for service when you do get reimbursement. We want to talk to you about the different channels, but this S code can be applied in fee-for-service, as many of you know that are getting reimbursed or some reimbursement, whether you're primary care, hospital, specialist, home health, agency, skilled nursing facility, or in a rural provider in fee-for-service. It's applicable if the payer does upload it into their system, and we're encouraging them to do so, and some have, and we're going to talk about how we can get them to expedite that. And then if you're in a capitation, some of you indicated that you are being paid in a capitated model. As many of you know, because of healthcare reform and other reforms happening at the state and level, most providers now are getting global payments with quality metrics attached to them. So the S code can be used under that scenario as well for tracking purposes, as well as for reimbursement, so that it goes on the claim form, so that the payer knows what they're paying for, and that the provider can also get paid for their services. So now we're going to go into the key channels that we think that can use the S code. Number one, can use the S code, but also depending on your patient panel and as a provider, how can we engage on these different payer types? So we have the commercial pay. The commercial is a primary target. As you know, there's many people in commercial plans, self-insured, employer unions. Then we're going to talk about Medicaid. As a result of expansion, some states are going to be expanding Medicaid, some not, and a lot of uninsured individuals are going to be in the exchange. Medicaid is going to grow from about 23 to over 36%, 35%, depending on who opts in. And then there are other payers as well, like AC, and then we're going to talk about ACOs. On this session, we're not going to talk about other key payers like TRICARE, which is growing, or even workers' compensation, where somebody gets injured and needs care at home, for example. But there are extended benefits there. We can always cover those with you offline. But we're going to really focus on the big targets today that can adopt these codes and pay you if they so desire, and we want to encourage them to do so, add reimbursement to these codes in order so that when you submit your claim, you get reimbursed. So let's start with Medicaid and as well as non-self-insured plans, which are called small group insurance plans. There are a number of states that do mandate coverage of telehealth, either through the Medicaid, whereby the state has submitted a state plan amendment to CMS and asked that telehealth be an optional benefit. Under that scenario, once they get the optional benefit and CMS approves the state plan amendment, which usually takes 90 days, and every state is different. Some states require the legislature to or to authorize the state to ask for to amend the optional benefit, or they can do it on their own depending on the scenario. Once they have that adopted, they then can issue coverage policies that can upload this code or other code sets for that matter. But this is an opportunity to engage them and also have a adequate reimbursement attached to those codes for your services. The other piece is, so you can see the number of states that have Medicaid coverage for telehealth. The benefit of that as well is that because the Medicaid program is a federal and state joint program, the federal government usually can kick in some money to the state to cover some of those costs under the federal match. For private insurance, which is a small group, you see in yellow and some of the dark blue, there are some states that require that small group 10, it varies on size, but it's usually 10 employees or less, or up to 10, can cover or are mandated to cover it under their policy. Those are usually regulated by the Division of Insurance of that respective states, and we're going to talk a little bit about the impact that has on health insurance exchanges. As you know, health insurance exchanges are launching this year. For 2014, and some of these plans are what are called benchmark plans. But we think that more states are looking at this this opportunity, and they can also use the S code or upload the S code and pay for those services to their providers that are caring for it. So what is really happening in the Medicaid market that we want to highlight to you is that it is growing exponentially, and we know that's why a lot of commercial plans are also purchasing a lot of managed Medicaid plans, or managed Medicaid is growing, and as we're going to show on the next slide, but this just gives you a quick snapshot of where the money and the population is, and either one of those states that do cover telehealth, for example, could apply it for those populations that they feel would merit or would qualify for those telehealth services. The breakdown of Medicaid fee-for-service versus managed care is, as we indicated, is growing. You could see most recent data that states are actually getting out of the fee-for-service business and moving more of their services into managed care. There are exceptions. Some states do carve out pharmacy, for example, or they carve it in. Some states, most states that do cover telehealth, as we've seen, that allow managed care to cover it. They have it in both options, or some of them require or they carve it into the managed care plan, and the managed care plan can then decide to cover it under an optional benefit. But if they do cover it under the cap, they do get reimbursed for it. So I think there is definitely an opportunity there. But really, the trend is looking more and more that states are moving populations and their Medicaid populations into managed care products. Just from our assessment, and of course, telehealth can be used in different settings, depending on the originating site. But for what we're talking about here today, and this code S9110, we believe that it really resides, or it's residing right in the home health and personal care area. A lot of care management organization, home health agencies, and home care are getting reimbursed into that bucket, and then the managed Medicaid plans that are now consuming more lives can also pay for their services under capitation. So one of the areas of concern that we hear and where we agree is that there is no adequate reimbursement for these services. So even when we get the codes, the reimbursement may not be there. We think that with all the money that's in the Affordable Care Act relative to Medicaid expansion, and including these new codes, may be an opportunity to engage payers, government agencies, private payers, Medicaid, and even the ACOs around investing in telehealth. And so there is going to be a lot of funding out there. The government will be subsidizing these programs. And as you can see, providers want more tools to care for the uninsured. There's going to be potentially over 30 more million new individuals coming into the system. And it's home health agencies, care management, primary care. This could be complementary to that. So we believe there is dollars there. It's a matter of whether we can advocate and be proactive. And we think there is an opportunity to do so. And Bill is going to talk about that further down, on how we can work together, partner together to really engage regulators, policymakers, and payers around the need to allocate some of the funds that they will be receiving towards adding additional investment to these services. The codes are there. The providers are there. The patients have asked for these services. Now it's a matter of reimbursement. So we're very comfortable engaging in that discussion as well. Bosch has been forward thinking in this effort, and it's been an honor and pleasure to work with them. Getting into the ACO side, there's about 25 to 31 million individuals, as you may know, that are either aligned with a government-sponsored ACO or a commercial ACO, or indirectly impacted, meaning they may not be in the quote-unquote ACO product because there's no such thing. You're not enrolled in an ACO in terms of Medicare. But you're now in a medical home, in an accountable care setting that is now treating you that way, or you may be a provider or payer that's under a contract under what is called an alternative quality contract. A lot of commercial payers have that for some of their design, which is literally the offshoot for the ACOs. A lot of ACOs are using their flexibility or using dollars out of fee-for-service to self-funding telehealth initiatives. They think it's such a strong ROI that they are actually contracting with home health agencies, care management organizations, and are providing reimbursement outside of the fee-for-service, Medicare fee-for-service structure. As you know, Medicare fee-for-service has some limitations around home health and telehealth, and this S code, we want to be very clear, does not apply to Medicare fee-for-service. We are working with Medicare around a lot of these initiatives, and hopefully we'll be successful. We'll continue on that effort. But in essence, an ACO, and you've seen this in the press, ACOs are adopting remote patient monitoring and are paying for that because they believe it's a strong ROI. It may not be within the fee-for-service budget. So how does the S code apply to that? The S code, they can still use it to track, to utilize, to upload in their EMR, to see exactly what was used. And so we are working with a number of ACOs as well around these initiatives. Next step, we're going to talk about case studies on how this can be applicable to each of these channels that we just discussed. So let's use one example of a commercial payer, Priority Health, that without us probing or asking, they, on December 2012, when the HCPCS codes were, the library of codes that the HCPCS working group at CMS puts out was released, they decided that this code should be used to not only amend their coverage policy, but to be added to their coverage policy. So if you're a provider that has patients or care for patients and that are Priority Health members, they do have a coverage policy, and under that coverage policy, this is what they cover. And it's broader than this. This is just a synopsis of that. And then the billing requirements. Of course, you need prior authorization. There's other steps that you need. There is a revenue code that's attached to the HCPCS code if you're using the HCPCS code S9110, and they have an allowance payment for it. We're not clear what that payment is, if it's the reimbursement rate for is, but if you do submit a claim with that code after you've done and you qualify, you would get paid for it. So they're one of the few payers that we've seen out there on the commercial side that has uploaded the code, refined their coverage policy, and has released it on their website for the world to see. For anybody who uses them who's in their provider network, you have to be a credential provider with them in their provider network. But in essence, they do use this code. We think that there's more work to do with them to educate them on some evidence and other things of that nature. But we believe payers like Priority Health are going in the right direction, and you could work with them to get additional information. We can work with you on that effort as well, and Bill will talk about that towards the end. Now, here's an example of a Medicaid managed care plan. United Healthcare, who does have a managed Medicaid line of business, that has a one-size-fit-all policy that we believe is outdated. Although they operate in multiple states that do has telehealth as an optional benefit, they have not updated their policy. So if you are a provider in home health or other provider that we've listed that has patients that you're caring for that are under United Health product, a managed Medicaid product, there are some limitations, and we're going to talk about how that can be applied. You have to use certain modifiers, claim CMS 1500 form like anything else. However, the codes are very limited. They haven't updated their policies in a very long time, or maybe they have not, because we do agree that payers are very busy. I was at CMS. I'm on a board of a health plan. I know how busy things can be, so they may have not seen this code yet. But we think this is an opportunity for us here to mobilize and providers and others to engage payers like this and tell them there is new codes out there. CMS has adopted. We think that there's new technologies and new evidence out there that you should take into and apply to your coverage policy. And more importantly, we think that the reimbursement, there's no reimbursement or not enough adequate reimbursement. So we want to talk about how we can make that happen as well. So they're lagging in their inclusion. So that's just one example of a major payer. On the Medicaid fee-for-service side, as many of you know, that's a different body. You don't go to a plan to engage with them, as you know. You have to go to the state itself. So in New York, you would go to the state of New York, and the Department of Health, or the Medicaid department has viewed telehealth as an important component of healthcare for its patients that qualify for remote patient monitoring. So in 2011, it did update its policy. It does require, this is what are some of the requirements. Its policy still, though, doesn't take into effect some evidence that is out there. So there is an opportunity to engage with them to expand or to even refine what is existing, but it's right on their website. They do require different modifiers and different modifiers specific to the setting, the originator setting or the setting whereby it's applied. Home health, for example, has some limitations in terms of where it can be used, and we think that's another opportunity as well. And the S code, which has not been uploaded, which we think is an opportunity to engage with them. They have updated their policies in the past. It's a matter of whether they're not even aware of this new code or new evidence that or new opportunities to be innovative. Once they decide that they want to, that they agree to upload the code and to pay for it, they do have a contract with 3M. 3M is their contractor, and a number of states have third-party administrators whereby they're the ones who manage the codes and manage the payments. They would then upload it, whether end the payment through an APG or other ways that they pay for it, and then they would then issue a release on their website indicating we've uploaded the code. We've in a best case scenario, we've uploaded the code. We agree this is the payment that should be applicable to it. This is our revised updated policy as of 2013. But in essence, this engagement with fee-for-service has to be direct. Providers can engage with them directly, and we're more than happy, and we've done it in the past, work with state agencies. We've done that throughout the country that can use S codes, and more importantly, they're getting a federal matching fund. New York, by adding telehealth, remote patient monitoring as an optional benefit under the Medicaid fee-for-service, actually gets dollars from CMS, and CMS actually encourages states and has a whole policy on that on their website to use remote patient monitoring to as a benefit for its patient that qualify, and if it does so, then it will get reimbursed. So there is an opportunity there, because they have reimbursement already for it, to basically align it with these codes or code sets to get you reimbursed. Accountable care organizations, as we indicated, ACOs are partnering with care management organization, home health agencies. Some ACOs actually own home health agencies or partner with them directly, in the home health agencies, and partner with care management organizations, and they're adding this service to their aligned members, self-funded. They believe so strongly in the policy and the ROI that some of them are just going about saying, well, fee-for-service is not covering, so be it. We have to report our quality measures. We have to improve outcomes. We have to reduce costs, which are some of the things that remote patient monitoring can help them do. So they're about partnering with others to make that happen. So it's a very exciting time, and this is all in the news. It is public information. The billing guidelines are ACO by ACO driven. ACOs have their own governance. They have their own operations. They have their own billing. Some of them may have their own dedicated billing structure to make that happen. But what we've heard from them in our discussions with them is that these type of new codes, like S9110, will allow them to track and to reimburse providers based on the reporting of those. So we think there is no uniform guidelines, but a provider can work with an ACO that decides to adopt the remote patient monitoring to then come up with the payment and to look at some of these codes to say, this is what this code describes. We think this is exactly what we're doing. Let's come up with the code set around the services and then a payment for that. So that's what a lot of folks are working on. It's such a new program, but it's very clear there's an opportunity there. Commercial ACOs, there are a number of them that have not yet adopted and limited contracts with home health, but there's an opportunity there. Next steps, as we indicated, is to work directly with the ACOs and come up with different arrangements. Last but not least, we just want to go very quickly on the potential access and reimbursement challenges. We talked about large commercial plans. These are your challenges. These are how you overcome them. You could either go with the large employers that do want to cover it. You can either go directly to them because they're self-insured. And if you're in the provider in the network or employer, some have been successful there. Small group, again, you go for those states that mandate it. You can work with them to increase access or upload the code for states that don't. Work with the Division of Insurances and the state regulators or legislatures to seek, hopefully, adoption. Medicaid fee-for-service, we talked about that and how you can overcome that, but there is opportunities. And then last but not least, the ACOs, they're looking for ways to improve outcome and reduce costs, and we think this is a key opportunity. Before we turn it over to Bill, who's gonna and the Q&A aspect of it, one thing we've seen in talking to payers, there is a value proposition to them as well. A lot of payers have to report now on the MLR, and with the yes code and maybe paying for these services on the administrative side, the yes code and the new remote patient monitoring, if they add it to their benefit, can be applicable around quality improvement expenses and can be a benefit. It can actually help them deal with some of these MLR issues. So this is another opportunity as well as, again, for the payers who are on the line who are limiting reimbursement to basically look at it from the aspect that reimbursement is probably adding these services, adding the codes, and adding reimbursement could also help deal with these issues of medical loss ratio as well. And with that, I'd like to turn it back over to Lori and Bill to get into the summary and to next steps. Thank you.
Thank you so much, Caleb. Don't go too far. We'll be having you back in just a few. I wanted to have Bill come back and just summarize some things for us in terms of key takeaways and how to continue the conversation. So over to you, Bill.
Thanks, Lori. So to just kind of give you a few takeaways of what Caleb's just introduced is that we believe that the S9110 is the best code out there to use for telehealth services. Previous coding, T codes and CPT codes that have been cobbled together to kind of address this don't adequately address telehealth reimbursement as well as the S9110 code does. Providers should encourage and facilitate adoption of S code by payers. As Caleb indicated, it's going to take a bit of a village, if you will, of providers who are interested in using telehealth to educate payers, regulators, policymakers around this S code and to work with them in making sure that it gets adopted so that providers can get paid for this types of services. Caleb also indicated that different payers have different policies, so you really have to look at who you're working with, what their key drivers are, and work with the key stakeholders within those organizations to make sure that the S code gets implemented in a way that's beneficial to you. To also emphasize that the S code, these HCPCS codes, ironically enough, are provided by CMS, but they don't cover Medicare fee-for-service. They're to be used by commercial plans and by state Medicaid agencies. So those are some of the key takeaways from this presentation. So Lori, I'll take it back to you for our next polling question.
I'll appreciate it. And folks, here is our second and final poll here on the screen. If you would just take a moment to weigh in, we'd like to know, based on today's webinar, which of the following would be of most interest to your organization. And in this case, you can choose all that apply, so you can select more than one of these choices. Is it best practices to start or scale a telehealth program, telehealth ROI models, clinical evidence and outcomes that support telehealth, reimbursement strategy and tactics, or perhaps you're not really sure and you'd like a telehealth consultation from Bosch Healthcare. All right, let's take a look. It looks like about 40% saying best practices, 49 telehealth ROI models, 56 clinical evidence and outcomes, 70% reimbursement strategies and tactics, and 5% not quite sure. So thank you again. And before we do address those questions, want to pass it over one more time to you, Bill, to let folks know where they can get some more information on the topic and continue the conversation.
Great, thanks, Lori. So we recognize that this isn't simple. So Bosch Healthcare has been working in this reimbursement space for a very long time, and we recognize all of the challenges that are faced by providers and payers around how to get it paid for. So to that end, Bosch has put together some toolkits that can be used by you, the providers, to help you get S-code reimbursement across several different payer groups. Medicaid managed care, Medicaid fee-for-service, commercial plans, and ACOs. We're developing sample letters with a model policy from other plans that can be used in relevant examples if your product is part of a larger commercial plan, for instance. So this information will be by payer source. It will contain instructions for use, and it will be available probably within the next few weeks in download from our website, www.bosch-telehealth.com. The other thing that we'd like to tell you is that we'll be at a couple meetings next month. The first one, I'll personally be at AHIP in Las Vegas, and we'll be at booth 556 where Bosch Healthcare will be presenting, and I'm happy to meet with any of you to talk about any of the things that were discussed today in more detail. Also, Karen Gilberg, our medical director, who I mentioned at the beginning of this webinar, who was actually the presenter of the Bosch Healthcare evidence to the CMS HCPCS panel, will be at the ACO Summit in Washington, D.C. during the same time frame, and is also available to chat with you about issues related to reimbursement. If you need anything in the meantime, please contact Rose Strain. Her contact information is below. She's our product liaison at rose.strain@us.bosch.com. She can facilitate and triage any requests around reimbursement consultation, how to meet us at the trade show, implementing best practice, et cetera, et cetera. So these are resources to you for follow-up activity after this webinar. So Lori, back to you.
All right, thanks so much, Bill, and would like to have Bill and Caleb back to our virtual podium and going to start with the questions. But folks, please note that a chat has been sent over with all of that contact information, so you have it at your fingertips. It will also be coming to you in the way of a follow-up email. This first question is going out to you, Caleb, and we'd like to know, how does the code apply to home health agencies who are buying telehealth services from a reseller and then using it with their hospital customers, mostly Medicare FFS?
Sure. So Medicare with home health, and this is one of the challenges of reimbursement that we've been dealing with and will continue to, is that under home health, the telehealth services are, very limited or not reimbursed. So it's a matter of really using this code again around other payer types, as well as really trying to working together around having CMS amend its policies to take those into consideration. If it's being used in the hospital, my understanding is that if that's the originating site, and it's being applied inside of the hospital, I believe there are reimbursements for that on a face-to-face. But once the patient is discharged, there are some limitations. But again, there are hospitals and others that are self-funding these services outside of the fee-for-service, whether it's with ACOs and others. So there is an opportunity there to have an engagement around outside of the actual fee-for-service reimbursement confine if they are willing to self-fund it because there's a clear ROI.
And this is Bill, Caleb. I think just to add on to that, we recognize that for home health agencies, Medicare fee-for-services is usually your best bet in terms of reimbursement, and that reimbursement from commercial plans and state Medicaid agencies isn't usually as robust. We see this is an opportunity for those that do have commercial and Medicaid business, those home health agencies, to go back to them to renegotiate pricing, add this telehealth as a benefit, and sit down and figure out how you can get reimbursed at a level that's commensurate with the value that you're providing back to the delivery system.
I agree. That's a great point, Bill.
All right, and Bill, this one coming from Cheryl, and Cheryl would like to know, telehealth is a broad category. Can you give an operational definition of what is covered by the term telehealth when using the S code for billing?
Sure. I think if we go back to the definition of the S code, and I don't know, Lori, if you can go back into the deck to the Superman slide.
Sure.
Is that possible?
Yes, it is.
Okay. All right. Because we do recognize that telehealth has lots of different interpretations. Bosch has taken the stance that telehealth is beyond vital sign monitoring and includes patient education, care management, as well as the systems that support it. So with that in mind, we asked CMS to provide us with a broader definition that included the types of services that we do in remote patient monitoring. So it basically says it's telemonitoring of patients in their home, including all necessary equipment. So that includes if you're using a box like a Health Buddy or a T400 and all the peripherals associated, like the blood pressure monitors, the weight scales, the pulse oximeters, the back-end computer system that's actually monitoring the answers to the questions that patients are providing, all the connections and software, maintenance, and then the clinical content, the patient education and support that goes into that. It's a broad, comprehensive definition of telemonitoring or remote patient monitoring that we've and it's not disease specific. You can see it's not just related to CHF. So we've tried to provide a broad definition so that gives you the best ability to negotiate pricing around the types of services that you provide within this definition. So hopefully that answered your question.
All right, thank you. This one for you, Caleb. Rick would like to know, does Medicare cover telehealth?
Yes, in some instances it does cover telehealth, depending on the facility, and they have a number of policies around that. Do they cover? There are some limitations specific to telehealth services in the home. As Bill indicated earlier, Bosch was involved in a demonstration project with Medicare, which was one of the longest demonstration projects in Medicare's history around trying to test these different services inside of the home, and it had some very good outcomes and evidence, which has been published in Health Affairs and other places. So we'll continue to work towards that effect. Yes, there are reimbursements to telehealth, but there are some limitations, meaning because of statute or other regulatory aspects of it.
And so let me add a little bit to that, because we're working all the time with Medicare to figure out how we can expand this kind of commercial Medicaid coverage to something that's much more from a national coverage decision. When you talk to Medicare, there's a couple things that they say. You know, we're enabling the marketplace, the delivery system, to pay for telehealth by, one, providing matching funds to Medicaid. So if the states decide to provide telehealth to their Medicaid patients, we'll provide money toward that end. We also believe that through the Affordable Care Act, that we've set up systems through ACOs and other organizations who are taking risk for populations of patients, that telehealth is a really good tool that these ACOs can use to drive better outcomes and lower costs, and that it's really up to you to kind of pull that through the system. That stated, they still believe that when you look at the vast majority of fee-for-service Medicare patients, that the need for a broader national coverage for telehealth is still, we believe, is still necessary. It's a dual-edged sword, because if you do get it, you get a price associated with it, which, you know, you have freedom in the marketplace. but at the same time, you get access to millions and millions of patients that you normally wouldn't have otherwise. So to that end, Bosch is working with Foley Hoag to work with Medicare to determine if, based on the current Medicare benefit, which of course was written in the 1960s, so I'm sure it did not envision telehealth, if there's a way to piece together or cobble together parts of those benefits in a way that could support telehealth. We're continuing to use the evidence that we've collected and that I shared with you at the beginning of the webinar is the foundation for the value of telehealth, since the outcomes associated with our interventions and the way we approach telehealth are all extremely positive. We continue to leverage that back to CMS for this type of decision, and we'll continue. We have meetings scheduled in late summer, early fall to kind of bring this back to them. So this is an active area for us. It's not just for us, but other people in the telehealth space, and getting Medicare to think about reimbursing it at a much broader level is important.
Yes, and absolutely correct.
Yeah.
No, actually correct, and they're indirectly paying for it through Medicaid, as we indicated. State Medicaid agencies that do adopt it are getting matching funds from Medicare or CMS to cover those services. So they're not covering for as Bill clearly, very eloquently indicated, around the fee-for-service population with 40 million lives. Some Medicare Advantage plans also, there's about 10 million individuals in Medicare Advantage. We haven't talked about that. As you know, it's not all fee-for-service. Some of them are looking to cover it under supplemental benefits or extended benefits and have done so because they believe there's an ROI, but they're going at risk, if you will. So there's still needs to be a lot of education around, and that's what we're working on.
All right. This question for you, Caleb. Carrie would like to know, how would I find out if my state has adopted policy? And Carrie's in Illinois.
Sure, we can definitely follow up around the policy for Illinois. Usually and we can go back to the chart to see if they're one of the covered states on a state by state. They would cover it under their state plan amendment. And then the medical group within the Medicaid agency of Illinois would then issue a coverage policy. But we can take a closer look at that. They may cover it, but it may be limited, or it may not have yet been updated to reflect the new changes in Medicare policy.
Okay. This one for you, Bill. Is there a way to get involved to help push CMS into reimbursing telehealth coverage, short of just writing to legislators? Is there a group lobbying, or what can we do at the home health level?
I think it's a great question, and we need as many people involved in this. Organizationally, the American Telemedicine Association, ATA, is our kind of professional body who has special interest groups within it who are focused in this type of arena. Frankly, over time, they've vacillated back and forth in terms of their political willingness or fortitude to kind of go after this. But I think they've recognized, particularly since the Affordable Care Act, this is something they need to be helping with. I also believe that NOC, the National Association of Home Care agencies, also provides some type of lobbying or overview. So I would try to focus your support back to your professional organizations, who can then act as liaisons with their lobbyists and others most effectively back to government.
Okay, thank you.
Sure, that's an excellent point. Excellent point. I think there's also an opportunity to engage federal employee health programs if they're covering the services. A lot of members of Congress, as we've seen, we're not lobbyists, but if that's covered under their health benefit, it's one of the areas where you can say, well, as advocating, we'd like to see be expanded as well. But yes, for Medicare specifically, Bill is absolutely correct. Work with your different professional groups.
All right. I think we have time for just one more question. This one for Caleb. And Myron would like to know, any insights on coding and payer reimbursement for telemedicine as it applies to patients and doctors connecting episodically via phone or computer for diagnosis and treatment of minor issues that don't require an office visit?
Sure. There are different modifiers out there that payers do have that I think it's a G2 or GQ and there's other different codes around reimbursing for services that may not be in that originating site, the physician's office, for example. We can follow up with you and get some clarity, but again, as we indicated throughout this session, every payer is different, and the pay and it is situational. So you may have a panel of patients that are in different insurance products, and that can dictate what code is applicable based on what the payer has uploaded into their system or has adopted in their coverage policy. But we can work through that with you, just getting additional information or getting additional clarification. That's a very good question.
All right. Well, thank you so much. And folks, we are at that time and would like to thank each of you for joining us today and hope you found today's webinar of value and that you'll want to join us for future events. Again, you'll be receiving a short survey at the end of the webinar, and we'd appreciate you taking a moment to fill it out. Additionally, for those questions that we couldn't answer on air, we'll have Bosch reply to your questions by the end of next week. And a copy of today's recorded webcast will be available as an on-demand viewing, and you'll each be receiving an email with a link in order to access this recording by early next week. Special thanks to our guests, Bill and Caleb, and our sponsor, Bosch Healthcare. And again, as your moderator, this is Lori Dearman saying thank you and have a great rest of the week. Goodbye for now.